Well, welcome. So I'm going to start out by quoting you guys because I think you have a ton of wisdom. So I love what people said before about entered to care, lost my soul. So the question is, we enter to care, but do we have to lose our souls, right? That's the question that we have facing us. We know that nursing, medicine, providing medical care is a calling. And so we ask ourselves, how do we support that? So the negative empathy curve that you saw on the screen before us is not something that's a foregone conclusion that we have to really tolerate and have as part of the middle stages of our career. Are there things that we can do to kind of even out that empathy curve and to maintain our humanity as we do our work? Because we all know that we come to this because we want to help people. So, imagine this. I'm going to start you out with an imagination exercise. You're a clinician in an oncology practice. You've been taking care of a man for 10 years since his first cancer diagnosis. Over time, you've developed a very friendly relationship with him. He's the same age as you. His kids are the same age. You have some similar interests. You really look forward to his visits. He's done incredibly well in his treatment. And then he has a significant recurrence, during which time he's in the hospital and you have to have some very, very difficult discussions with he and his wife and his family about end-of-life care. So you recognize that the end is near and the discussion turns to a discharge to hospice. So as he prepares for his discharge, you go to the floor to say goodbye, and you realize that unless you have time to go to his home in the next couple of weeks, this is probably the final time you're going to see him. All right, how do you feel? What do you say? Scenario 2, imagine this. You work in the emergency department. There's a young man who's brought in. He's very disoriented and confused. The ED is full, packed. There's stretchers on the walls. He's taken to that special room that everybody has in their ED. You find out he's a personal trainer. He's 6 feet tall. One of the staff describes him as having 0% body fat, right? A nurse and a nursing student go in to take his vital signs. He starts getting belligerent and agitated, starts yelling. A doc comes to the door of the room to see what's going on. The patient picks up an IV pole, getting ready to throw it. And the only reason he can't is because the tubing gets stuck between the mattress and the bed frame. You're the nursing student, you're the nurse in the room. What are you going to do with this, right? What's your reaction? What impact does this have on you? And how are you going to come back to your job and take care of the other people in the ED over the course of the day? Final scenario. An elderly man brings his wife of over 50 years into the hospital because she's having trouble swallowing. She's had dementia for 17 years. There are no children. He's taken care of her totally in the home. Every person who attempts to do an evaluation of her is kind of intercepted by him. He gets in the way. He starts intervening. He's answering questions for her. He won't let people touch her or evaluate her. He wants to figure out only how to feed her so that he can take her home and how to get her to swallow her food without aspirating. So the staff realize, of course, that there are too many risks, and they're starting to talk with him about whether she also is approaching the end of her life and whether they need additional services at home. But he's not hearing it. He's not interested, and he starts to accuse people of trying to kill his wife because they're talking about hospice. Okay? So these are 3 scenarios that are typical scenarios that you come across in a hospital, and that are presentations that were recently made in Schwartz Center rounds. And if you practice this enough, you can say it very quickly, Schwartz Center rounds. So the Schwartz Center rounds are the signature program of the Schwartz Center for Compassionate Healthcare. So what I want to do is tell you a little bit about the Schwartz Center. I want to tell you a lot about the Schwartz Center rounds and play you some video clips because I think you need to see some of what goes on and how these things work. But I think that this dovetails incredibly nicely on the discussion about burnout, because even though these rounds were not designed as ways to address burnout, we're finding that they are very, very, very effective in terms of helping prevent burnout. And I'm going to explain that all to you and hopefully connect the dots so that you see how this all happens. So that is my way of saying thank you very much for having me. I'm hoping that this really builds on the presentation that you heard earlier. And although it's not a tool in the sense of mindfulness or a relaxation exercise or a huddle. It's a tool of a different sort, which is really trying to provide something to your organization as a whole that might actually help you enter into some of the conversations that we need to have with each other in order to be able to sustain ourselves as clinicians and really feed ourselves. So let's start. So here we go. Okay, so I want to introduce you to Ken Schwartz. This is where the Schwartz Center starts. Ken Schwartz was a healthcare attorney who, at the age of 40, was diagnosed with an advanced form of lung cancer and died within about a year. He wrote and spoke incredibly eloquently about how important his connections with his caregivers were in the course of his treatment. So this quote is something that I think really exemplifies his position. I've been touched by the smallest gestures, a squeeze of my hand, a gentle touch, a reassuring word. In some ways, these quiet acts of humanity have felt more healing than the high dose of radiation and chemotherapy that hold the hope for a cure. The mission of these rounds is, of the organization is to do what we can do to bring compassion into the work that we do, to support each other in creating those kinds of connections with patients that are both sustaining for the patients and ultimately sustaining for us as well. And so there are many arms of this organization, but the one I'm going to talk to you about today is the Schwartz Center Rounds. So just to reinforce the mission of the Schwartz Center for Compassionate Healthcare, and you will hear compassion, empathy, connection. These are kind of the mainstays of this organization. To support and advance compassionate healthcare in which caregivers, patients, and their families relate to one another in a way that provides hope to the patient, support to the caregivers, and sustenance to the healing process. We are trying to cover many bases. This is not just about taking care of patients with the extra mile and the extra oomph that we bring to it, although it's a very, very central part of what we try to preach. But also, it's really about learning how to take care of ourselves and take care of our colleagues in ways that really support this very, very compassionate kind of care that we like to see people bring. So I want to help us dig into this a little bit. And what I would like to do, actually, is start you out with a little bit of an exercise. I know you've been doing this for days and weeks, but what I would love for you to do, and this will mean some people have to come up from the back, is to pair off in twos or threes and talk about a positive or memorable experience in which you received or observed compassionate care. All right? So in your small groups, tell a story. Think about when you were a patient, when a member of your family was a patient, or when you saw a colleague do something that you think exemplifies compassionate care. And just tell the story to each other, but be aware that what we want to do is really paint a detailed picture of what this encounter was like. So notice what words were involved, notice what actions were involved, and then what we're going to do is come back and just hear a few of these stories to kind of get us started in this. So pair up twos or threes and talk to each other. Well, it looks like you all have much, much more to talk about, but I want us all to come back. So would someone like to volunteer? I'd love to hear a couple of the stories. I heard little snippets, but would a few people like to volunteer just to tell their story?
Well, I'm telling mine from the patient point of view. So most people that know me and had to work with me this year know that over Thanksgiving, my brother had a very bad mountain bike accident when we were home visiting my family in Danville for Thanksgiving, and he actually had a punctured lung, 6 broken ribs, a broken clavicle, and a shattered scapula. And he's also type 1 diabetic, and things were very hectic, and things were very harried, and things were very frantic. And eventually we got him back to Richmond, where we live, but we were getting kind of conflicting advice. So it was like somebody over here thought he needed these x-rays, somebody thought he needed to be admitted, somebody thought he needed to do this, and we were kind of frantic and didn't really know what to do. So we have a physician leader that we know very well who is a shoulder specialist. So he kind of came in and just sat us down and said to my brother, put his hand on him and said, okay, you're not going to die. You're not going to die right now, and you're not going to die while you're sitting in my waiting room. So let's kind of unravel this and see where we are. And so what he did was he explained like why things felt chaotic to us. And he said, your primary care physician is trying to do the right thing and make sure that you can withstand surgery. I'm a specialist. I can bolt you back together so you can play golf again and ride your bike. Can't do anything for those ribs, but we're going to talk about how to manage your pain. And to my sister-in-law, it's her husband who's sitting there kind of in this shattered condition. She said, he's had a traumatic accident. This is hard, but nobody is going to leave here until we're kind of all in agreement with what's going on. And just somehow in the way that he connected with everybody, all of a sudden we just felt like, okay, we can breathe. And it was a very compassionate act in that moment.
Can you come up with three scriptures that you think really summarize what made that compassion?
He was honest and direct. He didn't give us a bunch of things that we didn't understand, but he told us what we were all worried about. We were worried my brother was going to die right there in his waiting room because, we hadn't done the right things. But he was kind of trying to validate the fact that we were upset about that and that we weren't making a mountain out of a molehill, but at the same time letting us know that that was not going to happen. And so all of a sudden we kind of all calmed down and we could process, what the steps were.
Sounds like he was very, very good at bringing people together, at having the patience to develop the consensus and the ability to really describe things in a way that you guys could get it, which is incredibly important. Thank you.
I think there's another key there.
Go ahead.
I think there's another key to what happened, and that was that the doctor or the provider, whoever he or she was or might have been, had a few essential things and took time to do those few things right. A list of 10 or a list of 12 is far too many, but he did the right simple things in the right way.
Right, so people can digest it, right? So people know what the plan is. Exactly, exactly, exactly. That's right. Do we have another story? Would someone like to tell one? Go ahead. Here.
We had a patient come into the ED, and she was not doing very well, probably was not going to make it. They had tried to get in touch with her family, finally able to get a hold of a mother who was probably 100 miles, 80 to 100 miles away. And she told the staff, she was just frantic. She couldn't get there. She had no money, no car, no way to get there. And so we had 2 patient access girls. This was on night shift. And, they were trying to get a hold of other family, couldn't ever get a hold of anybody else. The mother was saying, I want to see my daughter before she dies. It was just on and on. So it was very distressing for everyone. These 2 patient access girls, young girls, took it upon themselves when they got off at 7 a.m. to drive to pick up this mother. And she said, I can't pay you. I don't have any money for gas. They were telling us later when they picked her up from the house that they were really shocked that it was even inhabitable where she lived. But they picked her up, brought her back to our facility so she could be with her daughter, who was in ICU at that point. Didn't ask for anything, didn't say anything to anybody. We found out, actually administration found out about this just through kind of the story being passed along. They didn't, ask for any recognition or anything. They did that. So it was probably, a 160-mile trip for them after they had worked all night to get this mother to be with her daughter.
Right, so I asked the same question. What are the elements here that you think demonstrate compassionate care? Thoughts? Yep. Yep. Literally, going the extra mile, literally, right? This is way outside the job description, but shows a sense of how important it is for people to have the important folks around them at these moments. Any other? Strong sense of empathy. Yep.
They have to be able to put themselves in that position
some of the elements, and I'm sure there are many more. What I want to reflect to you also is that as I was walking around, you know, I heard little snippets of, well, this happened a long time ago, but it really sticks with me, right? These are the moments that that really stay with people for a very, very long time, both as the receivers of the care and as the providers of the care. You know, what we find a lot with Schwartz Center rounds, which I will explain to you in a minute, is that there are many situations where these cases are presented, and the ones that I happen to have told you about today are pretty recent, and the occurrences were pretty recent, but we find that people are dying to talk about things that happened 2, 3, 4, 5 years ago. The death of a child in the emergency room, that reverberates in a hospital or a facility for years and years, right? And people need a chance to talk about this. So I appreciate those comments. Let's see if I can get to the next slide. There we go. So this is just a summary. We are at the Schwartz Center constantly trying to refine our definition of what is compassionate care. And we come up with things with, like, it addresses the emotional and psychosocial aspects of the patient experience and our innate need for human connections and relationships. At its core, it means recognizing the concerns, distress, and suffering of patients and their families and taking action to relieve them. And some of these skills, active listening, empathy, strong communication, interpersonal skills, knowledge of the person as a patient, the patient as a person, sorry, including the context. I mean, that's the story about a young person being able to put themselves in the shoes of a mom, and the ability to work together. So these are the things that are ways that we try to operationalize these definitions in order to really start to bring them into healthcare facilities. So how do we do this? Let me tell you about the Schwartz Center rounds. So the rounds themselves are narrative-based. We make it very clear that these rounds are very distinct from teaching rounds, from M&M, from any academic kind of setting that we have in hospitals. Those are all incredibly necessary and perform a really vital function for us as providers. But we have found that people also need the extra piece, which is the time and the leisure, really, to sit down uninterrupted without the goal of having to solve a problem, come up with a treatment plan, address some kind of problem, but really just to have time to talk, okay? And so these rounds were created by the people who actually provided the care to Ken Schwartz in the Cancer Center at Mass General. And they came up with the idea that people really just need, like I said, to sit down and tell the stories and then have a chance to reflect on them and to talk with each other about what it's like to take care of people, what it's like to be taken care of, and the dilemmas that we face as providers so that we can continue to support ourselves and support each other. So the way this is done is by inviting people of all disciplines into these meetings, where we provide the forum for people to sit down and kind of discuss these things with the goal of exploring the human and emotional side of clinical medicine. But as this says, with the focus on the patient-caregiver relationship rather than the patient. Generally speaking, the presentations about the patient are really fairly concise and brief, and the presenters, and I'll get into the format in a minute, but the presenters actually talk more about their experiences and dilemmas that they face in terms of taking care of people, as opposed to the diagnosis or the treatment plan. We work really hard to make sure that this is a forum where we stay away from the clinical information in that way and really give people a chance to, to kind of talk about the human side of what we do. So, multidisciplinary forum, what's the purpose of that? We get a chance to talk to people that we never get to see. You think about a busy practice where a nurse doesn't really get to talk with the doctor. Yes, we have huddles, but they don't happen all that frequently, or it's a busy hospital setting and a respiratory therapist and a physician don't even know what they look like, what each other look like, and they're taking care of the same patient. We make it a place where people feel comfortable to talk about the emotional challenges by doing things like reinforcing that we ask people to keep the discussions confidential, by having facilitators learn how to evoke the kinds of emotional kinds of questions that we would like people to be wrestling with. We talk about the role that teamwork and communication play in improving quality. You know, what they really show is how people have a chance to sit down and talk to each other. One of the cases that's presented is about an emergency room situation. I'm going to actually ditch this because I don't think it's going to be helpful for me to describe it and just kind of go along. My apologies.
She doesn't think it's hooked up, so she's going to go get a line to try to hook up the sound from your computer.
That would be lovely if we can do that. Okay. Well, so let me describe a little bit more about the format of these rounds and talk a little bit. Let me finish up with the PowerPoint so that if we can get this done, we can get this done. And I'm having trouble actually getting this PowerPoint to work again. So just follow with me in the slides, if you will. So here we go. Let me hook myself back up. Sorry, folks, the technology is not my strong suit. So sample topics, if you'll turn to that page. You'll see that some of the topics that we talk about, these are really the kinds of things that are these are not black and white kinds of medical situations to deal with. Things like when everything you do is still not enough. Particularly relevant to this discussion, coping with burnout. So people will talk, we have had presenters talk about their own personal experiences with burnout, as well as stories about taking care of patients and what contributes to burnout. End-of-life conflicts, when caregivers make mistakes, a particularly difficult topic to talk about, but we've been able to actually find places and institutions where because the organization has worked very hard to make these discussions confidential, to be able to allow clinicians to talk about the things that we don't get a chance to talk about in other places. What happens when you make mistakes? How do you deal with that and continue to practice? The sense of isolation that people feel, the sense of shame that people feel. These are really not things that get discussed in public. And as we see, these are things that contribute to burnout in a major way, just because the isolation and the shamefulness and the burden that we put on ourselves to be perfect clinicians and perfect practitioners really takes a toll over time. So if you look at the next slide, which is the impact on teamwork, we find that these rounds, so there have been some research papers that have been written, one by our medical director, Beth Lown, published in Academic Medicine, that really looks at what is the impact that these rounds have on facilities and on caregivers. We find that in terms of teamwork, which is a really essential element of how these rounds are built, that there's an appreciation for the roles and contributions of colleagues from other disciplines and a sense of belonging. Again, very kind of anti-burnout important elements. I will tell you, I was recently at a rounds where medical coders were invited to come and talk about what their work life is like. And it was a really interesting topic and kind of a really not particularly typical Schwartz kind of topic, just because it's kind of really even out of the realm of Schwartz rounds. But it was absolutely fabulous because there were 3 women who are medical coders and sit in small cubicles and comb through every word of a medical record to find out what exactly they can bill for. And they talked about how when frequent flyers come into the hospital, there was a man, George, who has sickle cell disease. They come together and they talk about how sad they are that George has been readmitted. They comb the obits every day to find out which of their patients are alive. Did you think we can do this? Yay, let's do it. So let's see if we can get back there. Can you help me get back? Because I'm having trouble even getting that to work. So the question is, where did it go? There we go. Okay. So we need to minimize. Okay. Now, it had started, so I wanted to rewind that. It's not happy, is it? So while you're fooling with that, let me just, yeah? Resume. Let's just do that. There we go. Now can you hear? Yes? Okay, excellent, thank you.
Each one of us, if God forbid we get a serious illness and none of us know when or how, I didn't ever imagine it would be me, non-smoker, relatively good eater, worked out every day, that if it happens, God forbid, each of us is entitled and deserves the best possible care, not just of our body, but of our spirit and our soul.
The ideas that you're going to get from the Schwartz Center rounds are, you hear about other people's experiences dealing with specific patients in specific types of situations.
I have a 38-year-old woman with metastatic colon cancer who I've been treating for a year and a half, and she really believes, though her disease is probably progressing, that God is just going to cure her. And I can't tell you how hard it is to work with her, because I know that at some point the disease is going to get her. I know that she's not probably doing with her 4 sons what I think in her heart she would really like to do.
She needs to think how she is going to carry out her responsibilities as a mother right now. And she can think of things that have to be thought about and may take her mind off the fear. What do I want to do? Should we have some videotapes or
That was exactly the conversation I had with her. And she listened very intently. And then her husband told me never to talk about it again.
Right.
But I think the issue is, well, how do you talk about it then?
It's rocky ground, and if you're going to guide someone through an illness, I just don't know how to do it, basically.
The story is quite simple. It was December 30th, and I received a page that there was a woman who was about 35 or 36 weeks pregnant, who'd had some bleeding at home, and that there was a concern that this woman had a serous abruption. They brought the mom to the operating room, did a stat C-section, got the baby out as fast as possible, and out emerged a limp blue baby with Apgars of 0 who did not respond to pain, made no respiratory efforts. I think you're then in a dilemma, because if in fact this mother had a full placenta abruption about an hour and a half ago when we first got the phone call, this baby has not had any oxygen for about an hour and a half.
We really thought there was no hope here. The baby, this was going to be, we're going to call the code at 15, and we did our best. And at 14 minutes, I felt for the heart rate, and there it was. And all of a sudden, it's a whole different story, and you get really frightened. Well, you're excited because the heart rate's there and you've got a baby, but then you're worried about, how much damage has been done and what's happened and what's going on and what did we do, Was this the right choice to have done what we did?
The role that we played in that is something that I think none of us feel comfortable. That 30 seconds ago we were going to call this baby dead, and now we're calling him alive, and he has a name, and he's going to, because we gave him one more dose of epinephrine. And I just remember feeling that I knew how to do the mechanics of what I do, but I didn't understand what I was doing.
You're saying, I think, humbly, that you, didn't maybe know what to do or what you were doing. And, of course, we all get in situations where we don't know that.
But I feel in one sense that this mother and this baby and the family were fortunate to have had you there.
I had the identical case and the baby didn't die. And it was about 10 years ago, and I just happened to be visiting someone in the hospital and got dragged into a case of a patient bleeding saying, please do something. The last time this happened to me, the baby died. It's been 10 years. The baby does really nothing but drool. He's totally incapacitated. But the family thinks that the doctors in the hospitals were wonderful because we listened to them, did what they wanted us to do, and they do have a baby. And I guess I had to feel good that I fulfilled their wishes, but I don't feel good that I gave her such a devastating situation.
There is something about experience, and there is something about just doing the best you can in a particular situation. And if things really are a bad outcome, just remembering you did the best you could, but you're still allowed to be upset. And there are cases, patients and families that I can't shake for months, if not years.
As the day progressed and the baby got worse, and we could see that there was a significant amount of problems, it kind of gave me a feeling of this baby's going to die, which would be horribly bad, upsetting, but I turned around and thought, but at least Mom's going to be able to see this baby. We saved this baby for Mom to hold a live, warm, heart-beating baby to say goodbye. And so leaving my shift that day was a feeling of, I did do something good in a time where it's really bad, you know? So I knew what was going to happen, and I knew what was down the future, but I also knew that it was a better thing than having to say to a mom, being a nurse, your baby is dead, would you like to hold it? And then trying so hard to make this cold, blue, stiff baby look presentable and hold and feel good.
There's a Belgian French-speaking singer that most people know called Jacques Brel, and his line on this, and I'll say it in French and translated, is "On n'oublie rien, non rien de rien, on s'habitue, c'est tout," meaning you forget nothing, know nothing at all, you just get used to it, that's it. Which is, I think, what happens. These cases are no longer in the forefront of your mind, but they're there.
So let me try to cut this short right now and see if we can get back. So that is, it's a video that we like to show because we think it really demonstrates, some of the things that we try to create in these rounds. You can hear people really kind of talking about how even after years, okay, enough with this, enough with this. Stop, nope, stop, okay. How even after years, the weight of these situations really builds up for us, and how we carry these things with us, and how do we then have a way in which to make sense of them and deal with them in our own way so that they really don't impact us in a negative way, as in burnout, or as we were talking about, death through 1,000 paper cuts, right? I mean, there are situations where we don't have great medical outcomes. People die, people get sick, bad things happen, but how we sustain ourselves through those situations in order to be able to kind of rise again to provide the kind of care that we can feel good about for ourselves. And even if that means really ushering people to the point where they're talking about very, very difficult things with us. So let me just kind of get back to the other part.
2006.
No, we don't want that. Can I have a little help here also? Oh, that's right. Yeah. I need to minimize that. Then I just want to get back to the slide thing. Yeah, thank you. Great. Yep. Thank you. Good. Good. Okay. So sample topics. I want to buzz through some of these things because we talked about this. So we did not have a chance to talk about this. This is, really relates back to the burnout situation that people were talking about before, which is if these rounds, just by giving us the chance to talk to each other, give us a chance to cope with things in terms of the emotional impact in a better way, that is something that really feeds into how we sustain ourselves. And as well, there are many hospitals and facilities that report that some of the topics that are discussed really bring about particular changes in practice and policy over the course of time. Okay, just a summary. So this is where we connect the dots a little bit. So as we talked about before, I mean, if we can support caregivers, if we can build interpersonal connections with teamwork and kind of emotional skills for people, engage the patient voice, we find that staff feel supported, stronger teams, improved communication, and that, of course, leads to greater satisfaction and resilience in the workforce, and ultimately more compassionate care for patients and families. I mean, there was mentioned in the in the discussion before about how having the connections with patients really helps people carry out their treatment plans, and so it actually filters directly into medical outcomes as well. Although, again, the importance of these rounds is not so much in terms of how do we do this in a way that is directed towards patient care, but really giving us a chance to focus on taking care of ourselves and appreciating our colleagues. I mean, one of the things that you heard in this video, among other things, was the appreciation that people get to express to each other for having done these very difficult things with patients, a thing that we don't often get a chance to do. We're very busy and don't have a chance to actually appreciate the extraordinary care that is provided. So if we are doing this right, we hear comments like this, which is that these are places where people talk about the heart of the work, and a chance to enter into dialogue that really doesn't happen in other places in the facility. There's more heart in what we do with patients. The connections are deeper. We're less afraid of difficult topics. And the format allows for an exchange of ideas and feelings, reinforcing the common humanity of caregivers, patients, and families. And this, I think, really summarizes it. It's a place there, because of the difficult work that we do, this is a place where we come together and share support and validation for each other. And people who have these rounds find that it does fill a very important hole in their ability, in their institution, and reinforces their ability to provide quality medical care. So I wanted to just give a chance to open this up and see if people have questions. My apologies for the technological difficulties. So just in terms of information, we're now in 350 hospitals and healthcare facilities across 42 states. This program is expanding dramatically in the past couple of years and has really become something that hospitals have used both as a way to obviously to improve their morale and their ability to work with each other, but it's also something that people are using for magnet hospital status and other ways to kind of really, to bring some attention to their facilities. So you had a question, and then I see you. That is the question that we struggle with. However, there are a couple of background pieces to this. One is that we encourage the committees to actually get to know the culture of their hospitals in a way that they can tap into that. Some people do them at times where they have regular CME training. So once a month, they'll enter into a CME or a CEU time. Other hospitals really work very hard to specifically try to figure out times when people can come off floors. Right? What's a time that's less highly utilized time? Very frequently, they're held at noon. Lunch is provided. We encourage people to bring lunch and to give CMEs or CEUs to staff. So we encourage people to, to try to draw people in whatever way as possible. But I think ultimately the thing that does it is that the culture builds up in a way that people actually really look forward to this. When you've been in the hospital for 5, 6, 7 years, and people recognize that this is a time, literally, maybe the only time in your month where you get a chance to sit down face to face with your colleagues and talk about some of these things, that's the draw that we really find kind of pulls people in. People come in on their days off in lots of facilities to do this. So, but like I said, it does take that kind of appreciation for building that culture over time. So, and you had a question? Okay.
So how long did it take to get that team that's in the video to a place where they would share like that? Have they been together for a long time? Or?
So that was a video that was made probably 10 years ago, and I'm going to say that that hospital, so Mass General's been doing it almost since the inception, so 1996 maybe. It's been a long time. And Emerson Hospital was closely on the tails of that. So they were probably 4 or 5 years in when some of this stuff got done. But it's actually quite surprising is that there are some hospitals where it really does take time to develop that culture, and that's part of the facilitation and part of the teamwork and also part of the administrative buy-in. We encourage people to find speakers. If you find a very well-respected physician, a very well-respected nurse, a very well-respected, other clinician who comes up and is really willing to talk about the personal side, as you did. When my mother was in the hospital, or this really touches me because, I was up in against a situation like this just a few weeks ago and had no idea what to do, right? For us to be able to have a forum where we say, I didn't know what to do, right? It's really very supportive for people. So that does build over time. We find that some hospitals, they're just ready. And the culture has been building and building and building. And then this structure comes into place and people just grasp onto it. Other places, it takes a little bit of time to just form it. And that's the facilitator job and the physician leader job. So technically there are generally, to get this going, as I said, there's a multidisciplinary committee, but there are 3 principal players. One is the facilitator. And you didn't see the facilitator do anything in this because this was all, participants and speakers. But we have a facilitator who is in charge of the discussion, a physician leader who also joins in terms of helping the conversation stay alive and keep going, but is also kind of a role model, and a coordinator. So that's the basic team that kind of comes together to make sure that these things are up and running. Yeah?
I asked this question when I learned about the shorts, and I'd be interested in your opinion. Can you tell me about the physicians that tend to show up? Do you see that they tend to be more crunchy, granola specialties, or have you been able to get buy-in from some of them are more hardcore, like surgical specialties and things like that?
So that is the attempt, right, is that it's really nice to preach to the choir, but it's also really nice to kind of spread this around. And there are lots of ways in which we try to encourage organizations to do this. One way is to actually invite those physicians or those clinicians who are less likely to come and present, right? Or hospitals will, sometimes if there's an orthopedic practice, let's get a case from your practice. And then they want their people to come and listen to them and participate. And they can also be part of the panel. So it's a little subversive, but it's with the idea that we're really trying to broaden this to an audience, some of whom get it, but some of whom are just starting to get it. And that's what we want to really encourage, is that, that dialogue starts to happen and people actually start to think in these terms more than they're thinking technically all the time, right? I mean, the mission here is something like compassion is not something that we add on at the end of the day. It's not like I did this, my mammograms are up to date, my shots are up to date, blah, blah, blah. Oh yeah, and I'll be compassionate, right? That it's really a very integral, important part. And your stories tell that, right? I mean, that's the beauty of this, is if you try to really think about and extract what's the important part of this, it's that you feel like there is that human-to-human connection that all of us, as you were saying before, I mean, we're taught not to do, right? So we are, there are pieces of research out there on, is compassion something that you can teach? The answer is yes. right? We just have to start doing it. Is that something, at what phase of someone's career is it really important to do that? Certainly in training, as opposed to the suck it up and see one more patient, but to really give people the validation in the room to kind of bring that humanity in at a very early stage and then support it so that you don't see that dive in empathy mid-career, right? Because that's the burnout cycle. Yeah. Yeah. Right. Right, so we know that medical schools are really trying to address some of this stuff, but a lot of the teaching facilities, so Boston is full of teaching facilities, and and a lot of these happen, or certainly started in teaching facilities. So yes, we encourage people to have their trainees come, but even in the small community hospitals that have residency programs or nursing programs, or they're developing students, it's a wonderful part of, and it's a wonderful addition to the discussion, because you have people who are sometimes not afraid to ask those questions or not afraid to say, I have no idea how to deal with this. And other times, you see them sitting there and they're terrified to say that, but they're really starting to take in that their role models are people who are starting to kind of question and work in these gray areas that there's no hard and fast solution to, right? It's not like you're looking at an algorithm where it's like this treatment for this problem. I mean, you're really struggling with, where do you find the boundaries between being human and not letting yourself get overwhelmed, right? How do you talk with people about things they don't want to talk about? How do you, talk with someone about the very difficult things that nobody else is going to talk about because you're their clinician, and it falls on you, and still keep yourself fresh and able to continue to do this day after day, right? That's the really important part. So the trainees absolutely are a very important part of how we kind of encourage the growth. And, we're finding that, as the programs expand throughout the country, that it's actually trainees that are taking this. So somebody trains at Mass General, and they end up in Alaska, right? And they say, oh, we have this great program. Let's think about it. So we're finding that that's one of the way that it gets disseminated to people. How do you mean an agenda? Yep. Yep. So I will say I describe this sometimes in musical terms. I'm a music lover. So there's the Boston Symphony. Everybody knows exactly what they're going to do at exactly every moment. And there's improvisational jazz. Right? This is improv. And that's the beauty of it, actually, is that, as the presenters talk about their cases, there are certain themes that really come out very clearly. You're talking about to someone about end-of-life care. Or you're talking to a nurse who feels like, this guy's going to turn around and swing that IV pole at me, right? I mean, what does it do to you, and how do you then go on for the rest of your day? And what do your colleagues do, right? So it gets into all the nooks and crannies of how an organization works. But as much as you can kind of try to think about, as you hear the case, what themes come out to you, people react in their own ways. And again, it's the kind of the art of the facilitation is to feel comfortable with letting it go where it's going to go, right? And not letting it get very academic, but you'll have somebody, who shows up who is willing to say, when I was a patient in the hospital and I was waiting for my test results and nobody called me back, or I got the postcard, or I got the call, come into the office, and you know exactly where this is going, we want to encourage that stuff. So it wanders on a lot of paths. So yes, there are themes, and they're repeated and repeated and repeated, because there are so many ways to talk about doing the little things, making sure that you're relating to a person and the person doesn't become a case, right? There's so many ways to talk about that. Yeah. Yes. I mean, that's exactly it, is that, if you find people who are willing to role model this for people, and facilitators who are ready to ask hard questions and kind of get into that kind of discussion and not shut it down and really let people share with each other, absolutely. But you're exactly right, is that, in order for this to work really well, there does have to be that trust level. And like I said, that's the stuff that sometimes builds over time, and sometimes an organization is just so ripe for it that the first rounds is, people are talking very personally, and you know you're on the right track. Yeah. Yeah. Right. Thank you for riding that roller coaster with me. Go ahead. Yeah. And that is where we'd love to see this go, right? So this is the, when you start small and it really builds so that you can say, this is what I want to be doing, but does an insurance company recognize that this is what I want to be doing? Does my organization recognize that this is what I want to be doing? And where do we get the actual support to have this be the standard as opposed to this is the exception? So yes, there are kind of more political efforts being made to bring compassionate care into a standard of care, right? Into how we do this on a day-to-day basis, and to articulate that in a way. That is a big job. Yeah, yeah. Yeah. Yes, so all I can say is yes, there are efforts out there, and certainly I always hope that by this program becoming disseminated and really kind of a national program, and by the way, it's also an international program. It's now happening in the UK and Scotland as well. So by doing that, we're really hoping that it starts to have an impact on the healthcare system. Yeah. Yeah.
Remedies later on down the line. Have there been any cases of folks where after a fourth round, you admitted a mistake? I mean, I think that's why a lot of people would hold back, because they're worried not just so much as bearing their soul as, I hate to say it, bearing their pocketbook, and they're worried, hey, if this gets out that I admitted I screwed up with this, I'm going to get my butt sued. Have there been cases like that? I mean,
yes.
What are the ways around it? Is it legislatively y'all gotten around it?
Well, so there was an effort about a year and a half ago to have everybody start to talk, and this was kind of from the Central Schwartz Center out into the community. So you got me going on that. Now I can't say it myself, but to talk about adverse events, right? And so we asked if your hospital is ready, let's help you figure out how to do this. We make sure that there's no active litigation or threatened litigation, right? There are ways to talk about how is this protected, how is this not protected, so that you kind of know what territory you're allowed to enter into, because this is what keeps us up at night. Right? I mean, there are many things that keep us up at night, but this is a big one, right? Right, so it does depend somewhat on the state. I will tell the other way we did it was actually, so there were some hospitals that actually did take adverse events and talked about them, and events that happened in their hospital and clinicians spoke about, with really mostly about the impact on the clinician. The isolation, the shame, the embarrassment, how colleagues treat you, how are your patients looking at you after this is out in public, right? And how do you keep your wits about you and your soul so that you can continue to do your work. So that's really the thrust of it. But another way that we did this was to write up a scenario. So it was really removed from the hospital, but it was a situation that was full of medical errors in lots of different ways. It's a little kind of non-Schwartzy, but it was very effective in lots of places, just because it gives you a way to talk about some of the stuff where you're not really, you don't have to worry about, am I going to say something, or is someone going to say something that is going to get called into court at some point in time? So we're very aware of that, and it's a really important conversation to have, or conversations to have over time. And I will say, just as kind of an outgrowth of this, I mean, there have been hospitals where, after discussions like that, peer-to-peer support programs have started to develop. You've heard about these, right? I mean, so you're looking at me like, you know about them? There are programs in some hospitals where there is a designated group of people who've become trained to be peer supports to people who have been notified that a suit is going to be filed, and in a way that doesn't involve kind of protected and confidential information, to really reach out to them and kind of support them through that process. So that's one outgrowth of it, is that hospitals have started to develop these programs, or kind of there's a signature program out of one of the Boston hospitals, and to take that model and apply it to their facility. So, yeah.
As a patient, it's very moving to see that, and to see the level of sincere compassion those people had, and the sincere empathy they had for their patients, where sometimes as a patient, your assumption is that that's been trained and beaten out of everybody, but to even know as a patient that those people care that much, I think that would be healing in a way for them to see that.
Absolutely. Couldn't have said it better, right? I mean, it's a great statement, and it's the kind of thing that obviously the more people can get supported in being able to do that, the more it will come through in their work, and that's what we see, right? And that, P.S., it's not just about the feel good, touchy-feely, yes, I connected with my patient, but it actually translates into better medical outcomes, because people, they will work with you. They will take your recommendations for treatment more seriously if they feel like you've really taken the time to know them, their families, talk about the pros and cons, and spend the time to kind of really kind of march through the difficult decisions with them. So. Thank you. So here's another glitch, which is I had tried to ship down some information so that you actually would have some packets, but didn't arrive. So I'm happy to, they're going to be arriving because I know they're en route. So Amy has said if people are interested in getting some of these materials, we have an article called Ken's Story. Man, I'm really getting tied with this one. But Ken's Story, which is the article that was written in the Boston Globe about his experience. So it's a very extended article about his care and the impact that his caregivers had on him, personally by Ken. And it's a really touching article. We also have some little pamphlets about Schwartz Center rounds. So if anybody is actually interested in pursuing that in any way, you can get in touch with me, you can get in touch with the organization, and we'll try to make that possible for you. So if anybody wants that, I'm not sure how to do that. Should we collect names? Should we collect cards? So we can just send them? Great. That would be fabulous. So thank you very, very much. Yeah, yeah. I'm happy to have my inbox overloaded. I really appreciate that. Thank you again, and thank you for bearing with me through the technological problems. Yeah, thanks. Thanks.